Okay, next we'll talk about toxic metabolic causes of white matter disease. This is a list of diseases: osmotic demyelination, toxic lesions from underlying chemotherapy or other toxic uh, ingestion, Wallerian degeneration, radiation changes, disseminated necrotizing leukoencephalopathy, Wernicke's encephalopathy, and Marquis-Fava-Bignami disease. So osmotic demyelination is characterized clinically by rapid correction of hyponatremia. So you want to look at patients who would have a history of hyponatremia. So these are patients who are alcoholics, patients with diabetes, malnourished individuals, those with liver or kidney disease, those with syndrome of inappropriate ADH secretion. The patients can have subacute deterioration, which is within a few days. You should look for extrapyramidal motor symptoms, pseudobulbar palsy, quadriparesis, and this can progress to coma. On imaging, you typically see no mass effect or enhancement. The typical pontine myelinolysis involves a T2 hyperintensity within the central pons with a bat swing configuration, sparing of the outermost tegmentum. So you have a rim of pons that is spared. Extrapontine myelinolysis involves structures besides the pons. So that includes the thalamus, putamen, caudate, so additional deep gray structures. It can involve internal and external capsules, the claustrum and the amygdala, as well as the cerebellum. And you can also involve the cortex and the subcortical regions as well. Here's a 26-year-old woman with weakness and dysphagia. She had upper motor neuron signs and then history of alcohol. Here are the images pertaining to that case. So here's T1 pre-post DWI images, T2 and flare images. So what you see is there's T2 hyperintensity centrally within the pons with sparing of the periphery on T2 weighted imaging as well as on flare imaging. You see that there is T1 hypointensity and enhancement corresponding to active demyelination. There is some diffusion restriction in this, again, corresponding to acute demyelination. So this is a great classic case of central pontine myelinolysis. We'll talk a little bit about Wernicke encephalopathy. This is results from thiamine or B1 deficiency. It's associated with alcoholism most classically, but it can also be seen with other causes of thiamine deficiency, including starvation, patients who've had prior bariatric surgery, anorexia, as well as bulimia. And on imaging acutely, what you'll see is T2 hyperintensity with or without diffusion restriction enhancement involving the periaqueductal gray matter, the mammillary bodies, as well as the medial thalamic nuclei. Chronically, you'll see atrophy in these regions, especially the mammillary body atrophy. And symptoms include severe memory impairment. Toxic lesions can be associated with white matter abnormalities, so this includes drug abuse such as cocaine, inhalation of heroin, methamphetamines, isoniazid, metronidazole, different chemotherapeutic agents such as methotrexate. You have a specific entity called methotrexate leukoencephalopathy, as well as other medications, especially chemotherapy medications. With methanol ingestion, sometimes you'll get board cases on this. You can have optic nerve atrophy, putamenal and subcortical white matter necrosis with hemorrhage. I personally have only seen a case that a colleague shared with me, but I haven't dictated one of these cases before. Carbon monoxide, you can see T2 hyperintensity of the globus pallidus. This is not that uncommon. You can see white matter signal abnormality as well as involvement of the hippocampus as well. You can see diffusion restriction acute exposure involving globus pallidi. Methotrexate leukoencephalopathy is another toxic lesion, involves the frontoparietal white matter as well as the centrum semiovale. You can have diffuse periventricular and deep white matter involvement, and usually there's no enhancement or mass effect. And this occurs with high doses of methotrexate, typically with hematologic malignancies. It's less likely with rheumatologic treatment, for example, with treatment of rheumatoid arthritis. While area degeneration is also, of course, is a white matter type of disease and T2 hyperintensity, and it occurs due to antegrade axonal destruction from injury of the cell body or proximal axon. So anything that causes cell death can result in it, and it's important just to know that it follows a white matter tract and not to confuse it with other things. And then you have radiation changes. So there's a huge list of things that can happen with radiation. In addition to the characteristic T2 hyperintensity in their radiated fields, you can see radiation-induced findings such as hemosiderin deposition. Patients are predisposed to getting telangiectasias as well as cavernomas. And you can have mineralizing microangiopathy where you have calcification along watershed zones in the ACMCA and MCA-PCA territories as well as the cerebellum. You can also see high density in the basal ganglionic region. And we'll talk about this other entity called disseminated necrotizing leukoencephalopathy. This was first described in children with cranial and or spinal radiation combination with methotrexate for leukemia. In adults, you commonly see with methotrexate radiation. It's a progressive neurologic disorder. You can also have chemotherapeutic white matter injury. Most commonly, it occurs when chemotherapy is instilled directly into the brain through indwelling ventricular catheter, and then you basically have focal necrosis in that region, and that really keys you into the diagnosis. And you have transient white matter signal abnormality, which resolves with cessation of chemotherapy. The symptoms include decreasing mental status, seizures, and again, this can also progress to coma and death. With this imaging, you see predilection for the paraventricular region and centrum semia valley with sparing of the U fibers. On MRI, you see T2 hyperintensity with variable diffusion restriction enhancement, and occurs due to axonal swelling and gliosis as well as underlying coagulation necrosis. So here's a good case of a 54-year-old woman, history of diffuse large B-cell lymphoma. She had a normal MRI 2 months previously, and she was admitted to the hospital due to confusion. She has a history of meningitis, lymphomatous meningitis, and she was receiving chemotherapy with both methotrexate and rituximab through the Maya reservoir. So what you see is this area of T2 hyperintensity, the periventricular white matter with enhancement. And if you look closely, you can see it's right along the Ommaya reservoir that you see the enhancement. And there was some diffusion restriction as well. So this was a case of toxicity related to chemotherapy from methotrexate through an Ommaya reservoir.